Welcome, welcome. Went live fast today. Hi guys, it is me. I feel like I haven't seen y'all in forever. So I am so excited to be here. Of course, this is our first stream of the new year. Last week was New Year's Day, so we didn't have a stream. So Chris and I are back today for our first stream. So yeah, Chris is not here yet. You see just me. He's in California, tons going on. So he will be here. He's just running a few minutes late, but excited to join with him pretty soon. So welcome, welcome. Good to see you guys. I am so excited to be back and to share kind of thoughts, education, content, all the things that we love and that we're here for. So please make sure you tell us who you are, what your name is, where you're joining from. And of course, throughout today's live stream, our goal is that you will put questions, content, things you want to talk about, things you want to cover so that we can make sure we cover that together. My name is Liz McIngvale, and I, along with Chris Trondsen, love to run these live streams. There's been a little bit of shift in our live streams this year, so you'll start seeing me once a month, and you will see Chris weekly. I have told folks, but I'm about to go on maternity leave with twins, so my life will be a little bit crazy, but I will be here as often as I can because I love to be with you guys and share education and content. As always, our live streams through the International OCD Foundation are intended to be educational and supportive, but they should not replace therapy. We would encourage you to be seeking out individual therapy questions from a therapist and to use our feedback and education as guidelines, as support, but not as any sort of education or content to replace your individual therapy. Of course, if you're feeling unsafe or suicidal, we want you to do what it takes to stay safe. IOCDF is not a crisis line, and neither are our live streams. If you're feeling unsafe or suicidal, please call the crisis hotline at 988. Go to your local emergency room or call 911 if you're here in the US. And of course, if you're dialing in and joining from outside of the US, we want you to follow your emergency services guidelines. So thank y'all for joining. So great to hop in. Put your questions because we are going to start with those. It looks like we already have a couple. So I'm going to start with those questions. And then, of course, when Chris is here, we'll check in on him and jump in from there. What I will say, of course, is our hearts go out to those that were impacted by the New Year's Day event and, of course, the fires in California and so many things going on. So I don't ever want to run a live stream and hop on and not have a chance to talk about what's going on in the world that's impacting people in different ways. So of course, we are here to support and help and offer space and time. And we do know that these events certainly often also increase mental health and anxiety. So hopefully we can provide some support around the areas that's possible for us to do so. First question this morning is, can we do ERP by living our life how we want to live? Because by living our life, we'll automatically be exposed to the fear versus just sitting in a room exposing to fearful thoughts. This is a great question that I love. And the answer is yes and no. So after you've done effective ERP treatment, absolutely, right? The way that you do ERP is living your life. People will ask me all the time, what does ERP look like in your daily life? Or what does ERP look like on a daily basis? And the answer is that ERP should look like living your life, right? After you've done ERP and you've done effective OCD treatment and your OCD is well managed in the sense that you don't have current active fears that still capitalize your life, you should be able to live your life, and living your life becomes ERP. 100%, that is totally true. However, that is not necessarily the way that we're going to be able to do ERP from the beginning. So from the beginning, we do want to intentionally face these fears and intentionally do ERP so that eventually we can live our life as our way of doing ERP. Let me walk through that for a second. A good example is if a patient has any sort of fears, but contamination fears. Yes, if they are living their life, they're going to be exposed to contamination triggers. There's no doubt about that. And if they have the skills to be able to engage in ERP when they're triggered, sure, that will be great. Their symptoms will reduce. The problem though is that in order for us to see significant outcomes, which we want to be able to see when people are doing ERP, these exposures need to be done with full response prevention, and they need to be done with frequency. So we don't want you to face your fears or face a trigger once a month, or even once a week. For some folks, we need this to happen multiple times in a day to really be able to change that relationship with that fear, with that anxiety, with that distress, and to really be able to untie or untangle the hold that that fear has on that individual's life. So up front, we need to be doing active ERP, where we are intentionally facing triggers, even if we're doing it more than we would just by living our normal life, and we're intentionally doing things that are triggering to us, so that we can both get practice but also change our relationship with it. Once we no longer have things that are really triggering and fearful for us, yes, the way you do ERP moving forward is you live your life. But if, when you're thinking about living your life, you're also wanting to avoid, you're also feeling anxious about being triggered, that's when we need to slow down and do more active ERP versus just living our life as the way of treatment. Next question is, after facing an intrusive thought, and are we needing to avoid doing the compulsion or response to those thoughts as it doesn't care? Maybe the thought isn't true and we need to be uncertain. The answer is yes, right? Exposure therapy alone does not work for OCD. We need to do exposure with response prevention. So individuals must engage in no longer doing that compulsion after they do the exposure if we want to see behavior change take place, right? If you're doing exposures, but you're ritualizing, you're reinforcing your OCD cycle and you're going to stay stuck. But if you're doing exposures and you're no longer ritualizing, you get to change that relationship you have with that fear, with that OCD intrusive thought. Hi, Chris.
Hello. It is crazy out here in California.
Oh my gosh, I'm watching the news. I've been texting all the folks I know that live in the Palisades area, which I feel like a lot of clinicians we know do.
Yeah, a lot of
Worried
people.
about so many people. So give us updates. Tell us how you're doing. We're thinking about you. And is there anything we can do?
Yeah, so the winds out here are intense right now. And so where I live, there's something called the Santa Ana winds. And it's probably where the winds are almost the most intense. And so there's like trees that are knocked over. I couldn't get out of my complex because there's a tree blocking the gate. There's like shrubbery and trees in the freeways, on the streets. They're like cleaning it all up. So where I live, we haven't had any fires yet, thank goodness. But we're just ravished by intense winds and trees falling, brush falling, things, blocking off exits on the freeway, et cetera, not safe to drive. But in the Palisades, where a lot of clinicians, there's a board member that lives out there. I mean, it's just devastating. I have friends up there posting pictures and updates. A lot of people have lost their homes. A lot of people have lost their cars. A lot of people have evacuated. I think as of yesterday, it was like 30,000 people, but I think that number's gone up. So the people that are close to me, I have a couple people I do not know if they still have a home. So I think it's just intense, right? It's like brand new year. I think, everybody's like, this is going to be a great year. And it starts off right like that. So it's hard. It's tough. It's impacting a lot of people's lives and well-being. So I'm just at least hoping nobody loses their life. That's always kind of where you stand. We can always rebuild. I don't want to minimize the experience, but obviously, like, as long as people are safe, I think that's what's the most important.
100%. I was just starting the stream today with talking about New Year's Day in New Orleans and the fires, and it just feels like things are so heavy and a lot's going on. And so I was saying, of course, we want to make space for that. We never want to run a stream and not acknowledge everything that's going on in the world right now. And then in addition, thinking about the way anxiety and mental health just increases during these stressful times.
Yeah, I mean, I think, one of the things that people will always tell me is they'll say, like, one of the things of hope that they've gotten a message is from Jonathan Grayson, that when people have gone through exposure with response prevention, like, they're given a set of tools they can use in life. And I think that's definitely accurate, because for me, right, it's when I'm hearing from my friends, and obviously, like I said, I'm fortunate that there's not a fire currently in my area. It's just a lot of intense winds and things being knocked over. But it is that acceptance piece of just saying, okay, what can I control? What can I control? I can check in with my friends. I can make sure they're okay. I can offer anything I can do as support. And I can't, fix it, right? I can't ruminate about, like, why is this happening? And that was some of the stuff my OCD used to do. Like, when something bad was happening, I would sit there for days, if not weeks, if not months. Could I have done something different? Even in things like this, where clearly I don't have that kind of control. So I think it's one of those things for people. It's like, sometimes clients will say, does ERP mean I just don't care about things? It's like, no, you can care. You can genuinely want things to go well. And you can use your energy on the things you have control over and let go of the things you just can't, because you don't want to waste your resources in areas where you have no possibility to make a difference.
Amen. 100% to all of it. So next question is how to do habituation ERP and inhibitory ERP. And I love this question. And I think we talked about this quite a bit last week, or not last week, because I don't even know when I saw you last, but when was our last stream? Was that with Dr. Storch?
Yeah.
Okay. So our last stream with Dr. Storch, we talked a lot about this, about just kind of how ERPs evolved over time and what habituation models look like, what inhibitory learning models look like. Do you want to take a second, Chris, and just kind of explain what the difference is between habituation model of ERP versus inhibitory learning and what they both look like?
Yeah. So actually, when I did my thesis, there's a lot of work that John Abramowitz had put out on inhibitory learning. When we sponsored the BTTI here in Southern California, Alec Pollard talks a lot about it. So habituation is really, when ERP was created in the late 60s, the 70s, that was really the focus, is this idea that if somebody with OCD exposes themselves, whether it's in real life, so that's touching things, being around something, or through imaginal exposures like scripts, if somebody exposes themselves to it while practicing response prevention, they will habituate or get used to the anxiety, the fear, the terror, et cetera. So what that might look like in non-OCD treatment is it's like when you get into a pool and it's cold and you spend some time in the pool and you start to warm up, you get used to the temperature. And so that's really what we thought was the sole reason that people got better from ERP. As research came out in the 2010s, like I said, I read most of it through Abramowitz. I don't know if he was the one that discovered it, but what they started to recognize is there's also a lot of learning that happens in ERP. We actually had Michael, his last name is totally escaping me, but we did an inhibitory learning. I'll have to look up his last name, but Michael Heaton, I think it was, but he came on, did a masterful live stream with us about inhibitory learning. And so the way that Alec Pollard put it, that I think simplifies it, because a lot of people get confused, is we have learned with OCD, we kind of have in our brains like a safe category and an unsafe category. So I think all of us agree that swimming with sharks or standing in the middle of a freeway is unsafe. Laying in your bed or watching a movie with your kids, right, is safe. But people with OCD have put things in the unsafe category that are really safe. So maybe somebody walking into a public space or using their cell phone, they might think it's unsafe. And so the treatment, not only do you habituate to things, but you also learn. Your brain is starting to learn, like, wait a second, I don't think this thing is unsafe anymore. Chris is deliberately putting himself in this situation. He is learning from this experience. And the reason I think the addition of inhibitory learning is so masterful is because it's changed how I've treated clients as a clinician. I focus a lot on learning, processing. What did you gain from this? What insight did you learn? And also, how does that insight then impact other places? So if, a client is feeling more comfortable using other people's stuff, how does that translate to then being in public and touching other people's stuff? So I think sometimes people think that you have to do one or the other, but both happens in ERP. What I find sometimes is kids understand habituation more. I had a client, I have mints in my office, and I had a client that was afraid of touching the public mints. And as he kept doing it, he's like, oh, it's getting easier and easier, and I'm getting used to it. But I think some people like to focus more on the learning and the understanding and, why is my brain changing? Why has this become easier? Why am I getting better?
100%. And I think the big thing to talk about, we're going to put the link to that inhibitory learning with Michael Wheaton in the chat so that y'all can click on that if you want to.
That was it. That's what it
was.
So sorry, Michael.
Okay. But what I will say too, and I talked about this in our live stream with Dr. Storch, is that I think a lot of people are under this assumption that it's one or the other. Like you either do habituation or inhibitory learning. But what habituation is, let's just take a second to talk about it. It's something that we all experience all the time, right? So think about the last time you went into somewhere that smells. And every time you left, you automatically felt better because you were like, oh, I got rid of the smell. But every time you walk back in, you're like, oh, this smells so disgusting. I hate this. And you kept being re-triggered by that smell. Habituation doesn't occur because you continued to leave and avoid and then have to face it again. But if when you walk into that place that smells, if you stay in there and you don't leave, what happens? eventually you will say like, I don't smell it anymore. The smell went away, or I've gotten used to it. And in fact, you typically don't even notice it until someone else walks in and they're like, oh, it smells terrible in here. And you're like, oh, I didn't even notice anymore. Right. But you've habituated to that smell, because when you felt that urge or trigger to leave, you didn't leave, you stayed. And when you stayed, you kind of moved on. You moved through it, right? You walked through it, and you were able to have a new experience. Maybe you started to enjoy conversation or whatever it is versus be focused on that smell. And so you did habituate to it. And inhibitory learning could happen too, where you still had different experiences, where you were able to learn that, wow, I can not like how something smells, but still stay in a place and still enjoy an experience or still get used to it. But imagine instead if when you walked in, even if you decided to stay and not leave, if the whole time you were still hyperfixated on the smell, if every time someone walked in, you're like, don't you smell that? And you kept talking about the smell, and you kept being annoyed by the smell, and you were writing an email to the owners about how bad their facility smells, that would just make what you learn reinforce the negative part, right? That this place smells, I can't tolerate this, I hate this place, versus, okay, yes, it smells, it's out of my control, and can I move through it, sort of thing. And so I say that just because habituation is the concept that your anxiety will habituate, right? It'll fall on a bell curve, it will drop. And I want us to know that even if we're not, so let me back up, because some people might say, well, like, what is habituation-based ERP? So in the old days when we did ERP treatment, so a lot of facilities still do it just like this, we would have people do an exposure. So if my coffee cup is contaminated, we would say, okay, I want you to touch that contaminated coffee cup. And we would tell patients that you need to sit and not do anything else until your anxiety drops by at least 50%, and until you start to experience habituation. And I will tell you, by the way, that method kind of does work, right? Because you're still habituating, you're still doing exposures, you're not doing rituals, and so you're still changing your relationship with that coffee cup or whatever the feared object is. But the problem that most of us have noticed, especially those of us with OCD, is it's not practical. Right? Every time I'm triggered, I can't just sit and wait. Sometimes I need to take care of my kids. I need to finish a work product. I need to see a patient. I need to go run an errand. Right? It's not practical for me to just sit and wait all the time. The second reason a lot of us do not focus as much on habituation model only in the ERP process is because this model re-emphasizes that anxiety is important. Right? It tells you that like you need to wait for your anxiety to reduce to move on. You need to wait to not feel anxious before you do something else. And what we're actually trying to teach you is that anxiety is not dangerous. You can feel anxious and still go have a great time. You can feel anxious. I bet Chris felt anxious at the Golden Globes this weekend, right? I'm like watching your posts and like they're awesome and fun, but I'm sure you had some anxiety, right? Like, I mean, that's so cool, but also like, and probably a tense or high stress situation, right? And so both things can be true. We can feel anxious and still do really awesome things or still have great experiences. And so we're trying to teach you, can you see that both can happen? And so with inhibitory learning, we're focusing much more on, can we learn that, wow, I can feel anxious and still have a great time? Guess what? Habituation still often occurs. So even though you're doing more of an inhibitory model or lens in your ERP treatment, your anxiety should still drop. You should still habituate. If you continue to do exposures without response prevention, eventually those things should no longer be triggering and should no longer get you activated. But the difference is you're not waiting for the anxiety. The anxiety is not what you're putting all of the pressure and weight and like success measures in.
Yeah, well said. I think sometimes people will think that they're like two separate ways of doing treatment. And it's like both things really happen. A lot of it is like, what is your clinician focusing on? And what I'll say, just this is more just like based on like what I see in treatment. As I focused a lot more in the addition of inhibitory learning, I'm noticing the conversation switching in the office. An example is, in our IOPs, I really like to take people out of the office. There's a big mall next door. We'll go to the mall, we'll do things. And then it's time for the weekend. I'm like, what are you going to do this weekend? And they're like, well, I'm going to go to the mall by my place. I'm going to go to my friend's house because I learned that I was able to handle it. I was able to use my tools and really get through not only being at the mall, but thriving, having a good time. There's no reason to think that I won't be just as successful at the areas around me. So people are starting to connect the dots, recognizing like, okay, if I can do it over here, I can do it over there. But yeah, I mean, the main goal, I would say, bigger than this question is what Liz was just saying right now. I think all of us, before we get treatment, our goal is, I never want to have scary thoughts and I never want to feel anxiety. Talk to your friends, talk to your family that don't have OCD. Ask them, do you feel tense? Do you feel anxious at times? Do you sometimes have thoughts that you're like, wow, that was weird? And they're going to say yes. Now, obviously, it's a way different experience for us. But my point is, the goal is to not have no anxiety the rest of your life. It's more so to learn how to thrive and to coexist with it and recognize that you have all the tools in the world to be able to handle it.
Totally. All of us would love to not have stress and thoughts, and that's not always reality, right?
Right.
Next question at 11:05. Hi there. Can you talk about urges and the idea of acting on OCD?
Yes. So I'm trying to catch up with all the questions. Yeah. So one of the things that I don't know if people always recognize, but what we try to do in education for OCD is, it's not always just intrusive thoughts. It can be intrusive images. It can be intrusive impulses. So an example of like impulses or urges that people may experience is, they may be, if somebody has OCD harm, but more about self-harm and wanting to commit suicide, a lot of times people will say like, oh, I'll be on like an upper deck at a hotel and I'll have this urge to jump, or I'm walking down the street and I'll have this like urge to push a kid in the middle of the road. And so obviously that causes a lot of fear, and people mistake that. They kind of misassume what's going on instead of, giving it to the disorder. Instead, it's like, that must be something I want to do. And then obviously all of the compulsions start to happen, not going up, staying only on floor level, or when you're walking, making sure that you're never around people when you're walking on the street. What does that do? That reinforces and validates it. And now this thing that was a one-time incident starts to feel like it's your core being. And that's why separating yourself from the disorder is so important. So that's a lot of people's fears, Jack, is, what if these aren't urges? What if it's really like something that I want to act upon? But what I'd always tell clients is, like, people that have impulsive, there was a article for CNN that I kind of, they didn't quote me, but they, wanted to talk to me, just get some ideas, because there was a trend for a while about like acting on intrusive thoughts. The thing that the public is getting wrong is, there's a difference between intrusive thoughts and impulsive thoughts. So when you see like a TikTok video of somebody like grabbing, a donut and eating it from the store and running, and people will be like, oh, they're acting on an intrusive thought. That's not an intrusive thought. It's an impulsive thought. That's impulsivity, which we may sometimes see in ADHD. With OCD, we'll have these thoughts, we'll have the fear that we're going to act on it, and it scares us so much that we create so much avoidance and compulsions to avoid doing it. But we're not treating it like an obsession. We're not treating it like an intrusive thought. We're treating it like an internal desire, and that's probably where you're getting stuck, Jack.
Yeah. And I think I just want to add into this, because we've got a lot of patients, especially patients with like sexual intrusive thoughts with OCD, where they will have this fear that they're going to act on their intrusive thoughts, right? So they will say things like, well, what if I accidentally touch a kid, or what if I do these things? And so to remember, like Chris said, there's a big difference in history. Have you ever acted on these thoughts before? And intent. Do you plan to act on these thoughts? Versus with OCD, it's not just intrusive thoughts. It's unwanted intrusive thoughts, right? Mm-hmm. So these thoughts are distressing. They're scary. The individuals don't want them. They would do anything to get rid of them. So these are individuals that are afraid of having these thoughts. They're afraid that they might act on this urge. This is not somebody who wants to act on the urge, or who plans to, or has in the past. And so there's a big difference in that. And so for treatment, again, we're not asking you to act on the urge, because I wouldn't do that. You wouldn't do that, right? That's not what treatment is. Treatment is about, can you stop avoiding and start living your life again, and allow the urges or thoughts to be there, but choose to not do anything about them, right? Choose to not respond to them.
Yeah.
Next question, which is kind of related to Chris, is at 11:05. They said, one of my patients is suffering from sexual OCD and comes up with new symptoms due to which I cannot target sexual OCD. Any suggestions? And so I'd love to hear your thoughts on this, because I have thoughts, but I mean, we don't know exactly the question, but if we're kind of guessing at what it might mean, I'm assuming that they might mean like at times when patients have these sexual intrusive thoughts, like how do you do exposures for them and what does that look like, since we're not going to do something inappropriate or wrong?
Yeah, there's two ways that I like to treat this. So if I'm working with a client like you are, who is suffering from sexual related OCD, they're having sexual intrusive thoughts, and you feel like I can't target that, right? That's how we felt in 1966. They were turning people away and saying it has to be external OCD, and that's really what Edna Foa came in with the 70s with imaginal exposures. So I like to treat it two different ways. One is I'll ask the client, okay, when these sexual intrusive thoughts are coming up, what typically trigger it? And they may say like, oh, it's when I'm around children, or I'm watching a certain video, or there's a TV show I'm watching right now and I'm having a lot of intrusive thoughts, or if I'm out in public and I'm walking around and I start to notice myself kind of staring at people, right? So the thing is, a lot of times people think that the only way for someone to get better is to actually act on their intrusive thought. We don't have to do that. We don't have to tell someone, hey, the only way to get over your intrusive sexual thoughts is to actually do it and habituate to that, right? That's not what treatment looks like. Instead, we kind of back up a little and say, okay, these are all the activities you do that trigger these thoughts, and then you're doing compulsions, right? So let's go to those activities. E, exposure, and let's practice response prevention, not doing those compulsions. So an example, a lot of times a client will say, hey, I'm watching this show and there's minors on the show and I'm really having intrusive sexual thoughts. I'll ask them, what are you doing? A lot of times it might be avoiding, it might be fast forwarding through the scenes, or it might be doing mental compulsions. So what we do in session is we practice watching that show. I always try to do values-based exposures. So I'm like, what show is it? Let's watch it together. And let's practice not fast forwarding, not turning it off, but also more importantly, all of the mental rumination, the reassurance that you're doing, really practice that response prevention. Now, sometimes if someone's like, hey, it's not really triggered by any of those thoughts, I just have the thoughts pop up, then that's where we go to our imaginal exposures, our scripts. And what we do is we write out kind of these thoughts that people are having, and we practice engaging with those thoughts and really working on the response prevention. The reason response prevention is so important is because if we are doing compulsions, we are reinforcing and validating the original obsession, which is going to make somebody think that they're actually a bad person. When we start to go deeper, the core beliefs, the core fears is that they're this like kind of repressed, bad, evil sexual person. And doing all those compulsions, it's marketed that, hey, if I do these compulsions, I'll feel better and I'll get clarity. Compulsions equal confusion. You have to do the response prevention. So that's usually how I like to do it. What brings up the thoughts? Let's do those activities in session. If nothing brings it off, they're kind of like, I'm just walking down the street and the thought pops in my head. Imaginals can be very helpful as well.
Yeah, and what I want us to just kind of reiterate, and Chris and I have talked about this before, and we've done entire live streams on ERP not being fear factor, is that their ERP should feel values based. So a patient who has sexual intrusive thoughts, we're not asking them to do something that goes against their values and morals, or something I wouldn't do, or something that's illegal, or something that's taboo. We're not asking them to do that. Instead, what we're asking them to do is do the things that they're currently avoiding, right? So normal conversations, normal engagement in activities of going to the mall, going to the store, right? Like doing these normal things where these thoughts might come up, and choosing to not respond to the thoughts, right? And so there's a really big difference in that, right? I always tell people, and I just want to kind of new year, new reminder, but like I always tell people for exposures, I have 3 rules. The first is I'm never going to ask you to do something I wouldn't be willing to do. And guess what? Like, I'm not going to be willing to do something that's taboo, illegal, that sort of thing. Number 2, I'm not going to ask you to do something alone. So I should be willing to do it with you. Like, I should not be asking you to do something that I wouldn't like. I should be willing to go to the mall with you, to go do those items together, right? Like that sort of thing is a normal activity that I would do with you. And then the third is it shouldn't be a surprise. Exposure should never be, oh, this is contaminated. You walk into my office, I'm going to throw this contaminated item at you, right? It should be like, we've talked about it. We've agreed upon it. We both understand it. It makes sense. You're on board. You see the purpose of it, and we're doing it together.
Amen. And I think too, I mean, that's one of the reasons that ACT, acceptance and commitment therapy has been such a good asset to ERP as well, is that a lot of people, let's look at contamination, right? It is super effective. I was having this conversation because I know we've talked about it in streams, where sometimes like traditional ERP can even get like a bad, taste in their mouth. But I just started with a new client who had done treatment in the past, and they're like, hey, I have contamination. The most effective thing was when I would just rub the bottom of my shoes and lick my hands. And I was very authentic. I said, look, I don't really do that with clients, and I wouldn't do that myself. But if you find that helpful, who am I to say no? And it was like doing that quick and quick and quick and quick. And within like 4 to 5 sessions, because I'd gotten treatment in the past, they were doing really well with their contamination. But for a lot of people, that just is off-putting, right? And so instead we can do values-based exposure. So if somebody has fears about having dirty hands, an example of an exposure, we have a C's Candy right near my office. I'm like, let's go to C's Candy, let's get samples. The only thing I request is we can't do a compulsion prior. We can't go and wash our hands for two minutes and then not touch anything until we go and get the sample, right? So the exposures can be values-based. They can be things that you and your therapist discussed. And lastly, exposure shouldn't be a bad word, right? I think a lot of times ERP gets a bad rap and people try to paint it in a bad light. Exposures are things that eventually you're going to thrive in, right? So like Liz was saying, that coffee mug, I mean, how cool if that, I know that wasn't your OCD, but if it was, like, how cool can she be on a live stream drinking coffee and not have to sit there and like, not drink coffee or give something she cares up? I mean, exposures connect you back with the things that matter to you the most.
100%. Couldn't agree more. And I love C's Candy, so I'll come with you.
I'm obsessed. They're dark chocolate covered almonds. Allegra was back in town, and Allegra and I went to C's, and we had their licorice, their strawberry, and their strawberry stuff. She likes white chocolate. I didn't tell her, but I hate white chocolate. But we like tore C's up. That place is amazing. It's my favorite.
Yesterday, I bought this. I've like bought this granola. I don't know where I even got it, you guys, but it was so good. It's like this granola mix that had white and dark chocolate like within it. So it was just delicious. And I had it in my yogurt, and my kids saw me put it in yogurt. So then of course both of them wanted some. And so Matt comes to me last night and he's like, who buys yogurt with chocolate? Like, who buys granola with chocolate for their yogurt for our kids to eat? Like, who did that? I was like, might have been me. Like, they might have seen me doing it. He's like, they're never going to eat normal granola again. I'm like, oh, sorry about that.
Well, I'm even worse because I'll buy trail mix and then only eat the chocolate and throw the rest away. I'm like, it's healthy through adjacent. It was touching a peanut. So
exactly. Oh, totally. So next question from Robert at 1110 is, OCD is not contagious, as everyone knows, but with 100% certainty, as someone with OCD for 36 years, I can say that rituals are. What is the logic behind it?
I'm going to guess what I think Robert means. Do you think he means like hearing other people's rituals then become kind of,
and then we can pick them up?
Yeah, you know what, Robert? I would say it's funny because I run support groups, and that's probably one of the number one questions I get. People are like, look, I'm really afraid of joining your group because what if I hear somebody else's rituals and then I pick them up? And what I would personally say is 95% that doesn't happen. And I think it's because OCD always attacks something we care about the most. When you really go to that core fear, and we did a great live stream with Michelle Massey on core fears, that core fear is something we're afraid of becoming or afraid of doing, or we're afraid we really are. And so OCD is always important to you. Like my obsessions around, harming my grandma and my youngest sister. I mean, all those came from me being somebody who loves them and wants to protect them. But I will say, yes, sometimes people will come to group, or they'll go to a conference, or they'll watch a talk, and like they'll hear somebody doing something and they're like, oh my God, I've never thought of that. But here's what I always come back to. We cannot censor the world. There's going to be things that pop up when you're at a friend's house on a commercial that might trigger you. Your friend's mom might say something that triggers you. You might be out on the street and somebody mentions like, "Ooh, I read this article about this being dirty. Don't touch it." Or this food, causes cancer. So we cannot be in the mindset of avoiding learning about things because we might pick it up or we might be triggered by it. Instead, we should embrace that as an opportunity to overcome OCD.
Couldn't agree more. Next question at 1111 is, how would you do ERP for memory hoarding compulsions and just right around remembering things from the past?
Yeah, we call it like need to know OCD. It's where people definitely want to remember things, and just right. That can often be like a feeling. Sometimes just right makes sense to other people. Sometimes it only makes sense to yourself. And so, what I would look at for you is there's something that you're doing mentally, physically, or both. So sometimes I'll have clients that have the same obsession, and they'll take pictures with their phone so that they could remember something. Sometimes people will take notes or write lists or track stuff to remember things. Sometimes it's more people are having a conversation and they're like, oh, what was that person talking about? I got to remember it, right? There's something you're doing and there's a fear behind it. There's a fear that's driving this. So if you were my client, I'd say, okay, there's a reason that you are hoarding these memories. What are you afraid would happen? Is it more a just right obsession where if you don't do it, you're going to feel anxious and nobody likes that feeling and we're afraid it's going to last forever? Or is it that you might forget something great or important? So there's something that's driving the ship that you're feeding into and reinforcing. And what we would work on is dropping those compulsions, but on like a bigger scale, right? Like there's a reason that you feel like you need to do this. And so all of us with OCD have this sort of like set of rules that we live by because we have to do this thing to stay safe, but we recognize nobody else does it. So how have you kind of got conned in by the disorder that you have to hoard these memories? But an example of an exposure would be, let's say somebody is constantly waking up each day and trying to remember things. You can't do that if you're external and engaging in life. And so I can tell when a client's doing this because they're sort of tuned out and they're just in their head. So it would be being present, being focused. But I'd need to learn a little bit more on the fear, a little bit more on the compulsions, a little bit more on like how it's impacting you. But in order to think, real quick, I'll say, a lot of times people think mental compulsions are so different from physical. It's not. If I have a client who wants to get up and go wash their hands, sure, I can see that. But if I have a client that's tuning me out because they're trying to remember something from the past, that's an action, right? Like compulsive rumination is not the obsession. The obsession is, what if you forget this thing? The compulsion is, you're right, let me try to remember it. That's an action that you're doing mentally that you can choose not to do. So that's where we're going to, target that for sure.
100%. I will say one thing to add is when a lot of folks feel like, well, what do I do? Those thoughts keep popping up. If a thought or a trigger keeps popping up, that means we haven't fully addressed it. So a lot of ERP is just going to be about actually like talking through that past situation, allowing uncertainty to be there, choosing to no longer figure it out, but also not avoiding it. So if every time you have that past memory pop up, you're trying to like, I don't want to think about it. I can't have this thought. I need to get rid of it. The more you're actually empowering it, right? So sometimes it's just even talking about it neutrally, allowing yourself to think about it, allowing yourself to look at pictures of that time in your life or, past memories or things that might elicit a memory or a trigger around that and choosing to not do anything about it.
Yeah.
Next question, 1112 is, hi, Liz and Chris. If my core fear is just feeling off or feeling uncertain around having not just right feelings, and I have mostly mental compulsions, how do I lean towards uncertainty with this?
Yeah, I'm reading the second part. She says, how can I work towards being uncertain when I compulse so easily and find myself getting stuck on thoughts? I love your name, by the way, Terracotta. Ciabatta. Oh my God, it rhymes. That's so cool to me. Okay, sorry. What I would say is that just right OCD, right? I love having this conversation with clients because often they'll say, like, I don't really have a core fear, like it's just a feeling. But often when you take it a little bit further, it's if I have this uncertainty feeling, if I have this not, just right feeling, if I feel off, it is not going to go away anytime soon. For some people feel like it's going to go on forever, and I'm like, let's go deeper. What would that mean for you? So Terracotta, if you and I were working together, I'd ask you, let's say you were to have these uncertain feelings forever for an expansion, how would that impact you? And some of my clients will say, well, I'd never be able to relax. I wouldn't feel like myself. It'd be hard to pay attention in work and pay attention in school. So what does OCD ask you to do? It asks you to try to do these mental compulsions to feel your calm homeostasis so you can get back to life. But as you know, Terracotta, that's a con. OCD is a con artist, because what happens is now you have to go around and, like you said, you're easily finding yourself getting stuck on thoughts, which is causing you to feel off, which is causing you to panic, because that's the core fear of feeling off, so you can't engage in life. And then you're doing the compulsion. So the OCD itself is actually the thing driving the thing that you fear. So when I have a client that's doing too much, right? Some clients avoid everything, they just don't go anywhere. Their treatment's going to be more active. It sounds like your compulsions are super active. You're in your head and you're getting stuck on thoughts and you're mentally compulsing. Your treatment would be doing a lot less. So if I'm you and I'm walking and I'm starting to have thoughts and my brain is like, okay, you got to do those mental compulsions, you don't want to feel off, I'm going to actually let go there. That's going to be the opposite action. I'm going to say, you know what? I've learned what steps I have to take mentally to feel calm and to let it pass so that I can feel good again. But hey, that's been coming with a price. It's been reinforcing it. I've been stuck a long time. What if I try something radically different? What if I don't try to have the right thought or the right feeling mentally, and I allow this kind of discomfort feeling to occur? And I choose to bring that feeling with me in whatever I have to do today. I'm going to go to the store. I'm going to go to class. I'm going to go hang out with my friends and let that just right feeling live with me instead of trying to banish it. What happens is you start to build trust in yourself that you can be uncomfortable and function. And typically for just right obsessions, the fear is I'll feel uncomfortable and never be able to function, and my life will never be what I truly want it to be. OCD is going to be the cause of that, not the treatment.
Totally. Next question is, I have contamination OCD. I wash my hands a lot after I touch anything. If I went to a support group and one of the members speaks about a ritual they do and the reason behind it, I can find myself picking it up, especially if my mind finds the logic behind the ritual. Doesn't this in fact mean that rituals would be contagious? So yeah, that is what they were talking about earlier. And so the answer to that, Robert, is that the ritual itself, people with OCD can get triggered by anything. We saw this with Ebola. We saw this with COVID, right? We see this with lots of things where people listening to the news, all sorts of stuff, right? They can get triggered and then their OCD can latch on to anything. But when we say OCD is not contagious, what we mean is the disorder itself, right? So just because you know or see somebody else with OCD, you can't pick up having OCD. And you may pick up some rituals from other people, right? But what that means is that you still have core fears underneath it, that your OCD or anxiety is also attaching to those new triggers or rituals, if that makes sense. But yeah, you can pick up a trigger from anything. It doesn't have to be from another person with OCD. It could be a random conversation. It can be a news article. It can be anything.
Yeah, I had a client who was in class, and in their health class, the teacher was talking about germs, and they already started to have some contamination OCD. They're young, but it was like a 3-week thing on germs and stuff in class for their health projects, and they had to do like a project, and that completely opened the floodgates about germs. So a lot of times it's not even at a support group, it can be anywhere. And that's what we were talking about earlier, is we can't fear that. I do want to address something you said. You said, especially if my mind finds the logic behind the ritual sound. I think the thing is, like, a lot of times people assume that OCD is like all magical thinking. Sure, there's some OCD that has no logic, right? Like, I had a client once who was afraid that if they didn't blink a certain amount of times that day, that they would cause tornadoes in their home state, that came out for treatment. There's no logic in that, right? Like, unless you believe in X-Men and superheroes are real, like, there's no logic. But a lot of times there is, right? Like with COVID, it makes sense to wash your hands and wear a mask. It makes sense to be cautious around knives. Like, our brain doesn't just sort of like make something up. Like, we pick up information. The thing with OCD is we don't have an off button. So when everybody else was like, oh, COVID, let me sanitize my hands a little bit more, everybody with OCD went to the extreme. So it's not that there isn't. I tell clients all the time, like, that makes OCD sense. But if you look at your friends, your family, and people around you, they're not doing the same thing. So there may be some logic, but it's only a small part of it. And then our brain takes it to an extreme. And that's why we get caught up hours of compulsions.
Totally. Couldn't agree more. Inhibitory learning stream. Love, y'all are also sweet. Next question is, I've been told don't give any attention to the thought. Think of the worst case scenario. So if you think you just got HIV from someone, like maybe you touch blood, say to yourself, okay, I have it, and go, okay, I won't die. Get on with your day, but it's so hard. Interesting. So Chris, what are your thoughts on this?
Yeah, I mean, it's tough, right? I think even though ERP can seem manualized, I think people treat it different, right? And like one of the talks that Liz and I did is like, with I always forget to say the other two people, so I'm really sorry. Emily and Callie were with us as well. But we really talked about OCD treatment doesn't always have to be accepting your worst case scenario. I will say, like, when I sometimes I get referred an older client and they've done treatment in the 80s or the 90s, and it seems like that really, that was way before I was treating. So, it seems like that was more of the push. So I'll have clients that come in and they're like, I did hit somebody with my car, I killed him, I'm going to be arrested right away. And like I said, for some people, really taking it there can be effective. What I find instead, and this is just how I treat it, doesn't mean that I'm saying that's wrong, is let's say you get HIV. I was just rereading the question. Let's say you're out and you think you got HIV. Maybe you sat in a public restroom and you're like, okay, I think I have HIV. If this has been effective for you, you can definitely do that. But instead, what we really want to, what I think is more important to focus on, because I don't want to focus so much on the HIV, is when we all have OCD, something triggers us, and then we have some of that doubt, right? Like, do I or do I not have it? The trying to figure out is literally, in my opinion, one of the most detrimental parts of the disorder, right? We spend all day, whether it's physically, mentally, reassurance seeking, to try to get answers. So if we learn to be triggered, have this question, do I have HIV? And literally walk away. We're like, you know what? Not figuring that out. I'm moving on with my day. That uncertainty that I have around it, all of these feelings of doubt and not knowing and needing to get an answer. If I learn to not engage with that anymore, when that questions come up, because it's going to go beyond HIV, it's going to go, to something else. It's learning not to try to answer those questions. So the reason somebody might say is don't give attention to the thought is typically with mental compulsions, we're spending all day focusing on thought, trying to answer the questions. Now, if you find it effective to say, you know what, maybe I have HIV or I do have HIV, let's see, next time I go and get blood work, organically, we'll find out. I think it really just depends on what you and your clinician have found most effective.
Yeah, and here's what I'll say though is I want you to be cautious of this mentality or methodology with OCD, just because again, this is when we talk about we don't need to accept our worst case fears as truth, that it can be problematic. And because most people, a lot of people with OCD would not sign up for ERP treatment if they think this is what it requires.
Oh, Liz disappeared. She will come back. I'm going to let Liz finish answering that when she comes back. I'll jump to the next question at 12:15 your time, Emilio. It says from Eric, it says, my OCD tries to convince me that exercise is dangerous. Every day it tries to convince me that I'm going to have a heart attack while lifting. So here's the difficult thing about OCD. And thank you for joining us on X. I always like to see where people are joining us. We have X, we have LinkedIn, we have YouTube. The thing about that, right, is like, do people get heart attacks while being at a gym? Sure. But one thing OCD does is I worked with a therapist. She doesn't work with me anymore, but she used to tell our group all the time is like, people will take the least likely outcome and make it the most likely in their head with OCD. Or some clinicians will say, people with OCD take a lot of possibility and turn it into what's most probable. So I can't sit here as a clinician and tell my clients, you know what? You will never have a heart attack. Don't worry about it. I don't know. I'm not a healthcare provider, right? But how have you gotten to the point that you feel like exercise is dangerous for you? Have you gotten a medical and your doctor has told you not? Have you worked with somebody in your life? Hey, Liz.
Sorry, my computer died, you guys. Here I am.
No, it's all good. I'll finish answering this question and then I'll let you go back to answering your question.
Okay.
This question was just talking about like OCD trying to convince me exercise is dangerous. So what I was just saying is like, for you, Eric, if you have no reason to believe that this is, from like a doctor, et cetera, that this is going to happen, then, I used to have a sign in my old office that used to say no what ifs, because everybody will say that, right? With OCD, what if I have a heart attack? And the problem is you don't have any reason to believe that this is going to occur for you, but just the possibility has caused so much distress and so much rumination that just the thought of exercising is absolutely overwhelming. So if exercise is a value for you, if it's something that you want to do, it's something that makes you happy, remember, you don't have to jump to weightlifting tomorrow. Start by brisk walking, start by cardio if that feels a little bit easier. Work on lifting 5-pound weights, like work up slowly to it, because you're reteaching yourself like, hey, kind of that what if possibility. I was treating it way too intensely and it was convincing me to do something that, or give up something that I like.
Yeah, I couldn't agree more. And so what I was just saying is that um before my computer just died, went black on me, is that I think one reason I would say for us to be really cautious about feeling like we need to accept our worst case scenarios as truth is that it gives this illusion that ERP is this like cruel treatment. So, one thing I like to think a lot about, especially, is like sexual intrusive thoughts or pedophilia OCD, right? There's zero chance I would have done treatment if it meant I needed to accept that I might be a pedophile or I needed to be okay with that or okay with that possibility. Like, no, instead, I needed to be able to do OCD treatment, but to be able to know for sure and to feel confident that that is an OCD fear. That's not reality for me, right? Because again, that goes so far against my morals, my beliefs, who I am as a person, that we don't want patients to go through saying, okay, you have to believe your worst case fears are going to actually happen and you need to be okay with it, because many times patients are not okay with it, right? Even Chris has talked about a lot of his fears. If you think about a fear of like harming your loved one, like you're not going to do treatment and be okay with the thought, like be okay with harming your loved one, right? But we need you to be able to be at a place where you don't spend your whole life and day preoccupied with the fears that you're avoiding and not spending time with people you love, right? And so it's this balance that's really important. The other piece I'll say is that OCD wants certainty, right? So it wants us to know for sure that we're not this type of person or this thing isn't going to happen or vice versa. And unfortunately, we don't, not unfortunately, but like one thing we don't want to do is go one way or the other. Like, okay, well, I'm afraid of this. So now I'll just like, I'm afraid of getting sick. So now I'll just say I'm definitely going to get sick. Because in that point, you're still trying to confirm certainty or be okay with it. Like the actual ERP is being able to say, huh, I'm worried I might get sick and I'm going to choose to not figure that out and just see what happens. Right. So it's actually much more triggering and a bigger exposure for us to just allow space for the possibility that that could happen.
Yeah. It goes back to that idea of like, trying to figure it out is our problem, right? And in other areas of our life, we don't spend that much time trying to figure things out, right? Like if you don't have a fear around flying, you're not sitting there freaking out, how does a plane fly? But these things that OCD, zooms in on, typically it's because it's something that we care about. Yeah, it's that figuring it out. It is so empowering. I mean, I don't know how you feel in your own recovery, Liz, but it's so empowering for OCD to like bring you a message and, Chris, figure this out, and just simply being like, no, I'm good, and not figure it out. Like that muscle of just like letting go, being passive with it, and moving back to something I was doing is so empowering, because it's exhausting to get triggered. And it's like your next 3 to 6 days is now being consumed with this thing, and it's going to drop off and a new thing will come up, and you're just chasing whack-a-mole, and it's exhausting.
100%.
Yeah. I'll ask you the next question. So it comes at 1216 from Isostasia. What do we do when our core fear and the theme of our OCD is objectively in the unsafe side? So, if somebody's core fear really is something unsafe.
Do you have an example?
Yeah, I would say, like, I get this question a lot when someone's like, well, I'm afraid of getting cancer, and cancer is unsafe.
Yeah.
So, yeah.
Yeah. And again, same thing with violent intrusive thoughts, sexual intrusive thoughts. Like these are things that we're not okay with, right? And so treatment isn't about, oh, I want you to be okay with the possibility that that's who you could be. It's about, I want you to be okay with the thoughts. I want you to be okay that the thoughts can come and go and they don't have to mean anything. So can we quit attaching meaning to them? So when we think about cancer, for example, I actually had a patient recently who was immunocompromised. And so they said to me, well, some contamination exposures could be dangerous. And I said, okay, well, that's a really good thing for us to think about is like, what would your doctor say is safe versus is OCD behavior? So, what would your doctor say is something that is safe for you to do, but your OCD makes you think it's not safe versus something your doctor would say, no, you truly should take these precautions, right? Maybe you should wear a mask on a plane or in certain, whatever it might be. And so we want to be able to differentiate what actually is safe versus not. And again, we should only ask you to do exposures that if we were in your shoes, we'd be willing to do, or vice versa. And we do those together. It isn't about us saying, okay, I want you to purposely go do something that might cause you to get cancer, or you're afraid of bloodborne illnesses, I want you to go touch a used needle. Like, no, I wouldn't do that. You shouldn't do that. It's not recommended. It's dangerous. It's risky. But do I want you to be able to no longer avoid going to the doctor and be willing to get a blood draw that you've been putting off for 2 years that you really need for your health and for your, for your own medical knowledge? Yeah, I want you to be able to do that, right? Because that is a within reason practice that is safe and that people should be doing. And so it's about us being able to say, where is OCD taking it to beyond the norm, right? And having these rigid rules and this rigid kind of way that I have to respond or function versus what is actually a safe practice for me. And again, that's different for different people, right? During COVID, different people had different beliefs or understandings or practices around safety based on their circumstances. If you lived with someone who's elderly, if you're immunocompromised, right, you might have done things different than somebody who was young, healthy, and living on their own at 25 years old, right? And that's okay, but it doesn't mean we have this one size fits all. What I will say though is that the core fear is less about us saying, okay, we want you to be unsafe, and more about us saying, okay, yeah, I have this fear, right? I am afraid this thing could happen. I'm afraid there could be this outcome. And I'm going to choose to still live my life this way despite that. So it's about, like Chris said, choosing to not figure things out, choosing to not live your life in this rigid way where you try to prevent any sort of thing from happening and you're going way above and beyond and it's interfering with your functioning because you're more worried about your OCD fears. So it's about how can we live our life, allow space for our distress and uncertainty, and choose to not do anything about it. That's not the same as saying we need you to be okay with these unsafe things or we need you to engage in unsafe behaviors. We would never ask you to do that, nor would that ever be recommended for OCD treatment.
Yeah. I'm gonna ask the next one. I like this question. Alex, she wrote, said, "How do you deal with compulsions that make you feel like you're being risky? Like if I'm driving and someone is wanting to turn, I may slow down a bit. Then I'll say that was risky." So, you know, I hear that from clients a lot. They're like, "Oh, if I do the treatment, I'm going to start feeling like I'm reckless or risky or kind of out of control."
Yeah, remember, OCD is going to tell you this about anything, right? Anytime you're doing exposures, anytime you're doing normal activities, OCD is going to try to throw at you why you did that wrong or how you should have done it different or what wasn't good or what was bad or whatever it might be. It's about being able to say, okay, what would someone without OCD do in this situation? And or being able to say like, okay, yeah, like wow, I'm slowed down and I'm worried that that feels like that was kind of unsafe, and what can I do about it? I'm going to keep driving anyways, right? You already slowed down. You already did that behavior. So you might as well, like, nothing you can do about it at that point, regardless. But again, this is where it's really about what is the core fear and what are we doing to do active ERP around these things instead of just every time we're triggered, we're trying to respond with response prevention. I instead want us to get to a place where we're not actually triggered when we're driving.
Yeah, and I would say too is like you are going to potentially feel, I tell clients a lot. I'm like, you're probably going to feel like you're being risky or reckless. The thing is, you've done, the part of your brain that tries to keep you safe, like the orbital frontal cortex that's like, hey, danger, is so overactive. When we looked at fMRI studies, your brain is overactive in the part that wants to keep you safe. And so it sees a lot of things as potential danger. And so the problem is you've gone and overboard, right? So somebody, for instance, that is maybe using a knife around family members, it's like, they're making sure that they're using the knife on the side away from family members, or they're using a very dull knife. So if they do accidentally stab someone, it's not going to harm. I mean, there's all this extra safety behaviors that people are doing. So just moving back to quote unquote, like the range of normalcy is going to feel risky, but it's going to feel risky in the context of OCD and not in real life. And that's something you have to remind yourself is just like, look, like I'm being asked to do this, in collaboration with my clinician. And like Liz was saying at the start, right? She has those 3 rules for exposures. You got to start kind of trusting your clinician much more than you trust the OCD messaging.
And one thing I hear all the time is people will say things to me, and I'm sure they say the same question to you, Chris, but people will ask, like, well, how do I know the difference? Like, how do I know if it's actually risky or it's OCD? And as someone who lives with OCD, I'm curious if you would disagree with me or agree, Chris. I always say, like, you know the difference. Like, you know when something is actually risky, actually dangerous versus, nah, if I didn't have OCD, I would be doing this. Right. And so that's a question to ask yourself is if you didn't have OCD, would you be doing this behavior or not, right? Would you be washing your hands right now? Would you be running that extra wash cycle? Would like there's a difference.
Yeah, it's crazy now upon reflection. I mean, part of the I was so isolated, housebound for 3 years, right? Such in like a fog. And one of the things I remember my clinician, Karen Pickett, said to me, she's like, "You're so hyper focused on your world, right?" She's like, "I want you to start to like zoom out a little bit and observe, like, what are people around you doing?" And it's like, oh yeah, I'm running, like you said, things on a wash cycle twice, or when I'm at the store, I'm trying to move things, so I grab the last one, or I was afraid of harming strangers in public, so I'd sit there and try to find like the least populated line at the grocery store. But when I started observing, I'm like, nobody else is doing these things. And so I remember we made an agreement of like, she's like, if you had to stand up in front of 1,000 people on a stage and say what you're doing, do you think most people would nod along, or do you think they'd be confused? And I didn't need to use that my whole expansion of treatment, but in the beginning, when I think I literally was kind of a little bit unsure. But just like you said, like once I really got the education about what OCD is and isn't, right? I knew when I was asking a reassurance question that it was definitely OCD and not just like a conversation starter. So I think that's what I tell clients a lot is we got to be honest with ourselves. We know it's OCD. So don't kind of try to lie to yourself. Just be like, hey, this is OCD and I feel urge to give into a compulsion, but I'm clear that it's the disorder and not me.
Yeah, it's just kind of like that question I'll get a lot of times from folks will be something along the lines of like, well, how do I know if this is OCD or not? And how do I, right? And my answer is always like, sorry, not even OCD. We've been talking about that, but like what exposures to do. And sometimes like I will, when people say to me, what exposure should I do? And I say to my patients, like, what exposures do you think you should do? Right? Because you often know the things that you feel like you should be doing, right? The things that man, I actually, and so like Chris said, sometimes even our patients will say exposures that they think they should do because it'll be helpful that maybe wouldn't even be ones we would do normally or we would guess to do, but it's what's in their best interest, right? And so what's either worked for you in the past or what you feel like is going to really help push you and you just want to jump in and do it. And so be thoughtful about that. But again, the biggest takeaway as we go into the new year and you guys start to think about goals that you're going to set for yourself around OCD treatment, outcomes, and the life you want to be living that I hope is no longer controlled by OCD is, can you understand ERP as a treatment that is empathetic, that's compassionate, that's warm, and that should feel really good? Yes, it's going to be hard. Yes, it's going to be triggering. Yes, it's going to be anxiety provoking. But ERP should get you back to that life that OCD has taken away from you. And it should feel rewarding. And even during the process of ERP, it should feel a little bit fun. It should be exciting at times. You should be laughing with your clinician. It shouldn't always be this difficult, scary, terrible thing, right? There should be rewards built into that. And if you feel like the ERP you're doing or you've been doing doesn't align with your values, that you're doing things because your clinician's telling you to do them, but you really wouldn't be doing them otherwise, and they don't really make sense to you, it's okay to question that. And it's okay to talk to them about that or to think about switching clinicians because ERP should be values based. It should make sense. And I will tell you, there has never been an exposure I've done in my life where while I'm doing it, I'm like, I disagree with this. I shouldn't be doing this. This is wrong. Now, yes, there's been many exposures where I've been like, I don't want to be doing this. This is scary, but I always knew why I was doing it and it made sense to me and it was getting me closer to the life I wanted to live.
Yeah, no, that was beautiful, and to just kind of maybe bounce off that a little bit for my kind of like new year, my hope for anybody watching this, for all the people watching this is just, I tell everybody it's not a race. You don't need to look at the people in your support group or online or in comments like how they're getting better, but there should be forward momentum.
Mhm.
I always say to my clients, like when the head hits the pillow at night, is there something you did to push back against the disorder? Did you go to a conference? Did you listen to a podcast? Did you offer to drive instead of your partner so that you could practice driving? Like, is there something you did? And so that's what I've been talking to clients about for the new year. It's like this can be the year where OCD is not the majority of the problems in your life. You can start to see its impact on your life shrink and shrink. You just got to do the work. And you'll always remember 2025 was that year where I took it seriously. I put in the work, started educating myself, like starting to push back. And then 2026 and beyond, you get to look back and be like, man, I'm so proud of myself that year I made it a top priority. So I hope everybody watching this makes it a top priority because people like Liz, myself, and many other advocates, we're always trying to remind you that you can get better. And not only can you get better, you can thrive, like Liz always says. And you also can start to get to a point where OCD is not the predominant worry in your life. And that's amazing.
100%. Well, thanks, you guys. It's great to see you. As stated at the beginning, I will see y'all now once a month, every first Wednesday of the month. But Chris will be here for all the others with our exciting new live streams and content. And of course, you can always go to iocdf.org/peace of mind to learn more about our upcoming live streams, our live stream schedule, and to submit content or education or thoughts that you want us to be sharing. Thanks, you
Absolutely.
guys.
Thanks for being
Happy
here,
New
Liz, and
Year.
thank you so much, everybody. Have a great new year.